Alrighty, hello friends. So today I am going to do your guys' renal review. I apologize that I have been so MIA. I literally feel like I fell off the face of the earth, but like I said, I had to finish all my preceptorship hours this week, and then I'm moving to Central Illinois tomorrow. So I literally have just been packing, sleeping, or working, or precepting. That's it for the last week. But it's okay because I'm here now and I'm going to get you guys ready for your exam. So I have not reached out to Dr. Schneider yet and gotten a list of everything for for the neuro exam. He sent me just a list of the topics that you guys were going to be tested over. It was what I thought, so it wasn't a huge deal, but renal, I will probably reach out to him after this and just make sure that I got everything covered, since I will be doing one more video this weekend for male reproductive, so BPH and stuff. So that way, if I miss anything in this video, I can just include it in that. But I feel like I have most of everything figured out. So I'm going to get started because I know this is going to be long, but comment your email as always, and if you have questions, feel free to reach out to me. I've had a lot of you guys reach out so far for renal, so that's great. I'm here to help you guys, and it's no trouble at all. Just know I might be a little bit slow if you text me or email me tomorrow or Saturday, just because I'm moving. But yeah. Okay. So the first thing that I am going to talk about is AKI and CKD. I feel like AKI, or acute kidney injury, and CKD, chronic kidney disease, are probably the two biggest renal disorders that you need to know for this exam. This might make me sound like a nerd, but I actually really enjoyed renal content, and I think part of that is because for clinical, I was on 16400 at Barnes, which is it's GI and then abdominal transplant. So I had a lot of kidney transplant patients, and so I actually got to see AKI and CKD literally every week. So yeah. All right, so we're gonna do AKI first. So acute kidney injury is just it's acute, so it's very rapid, and it's just a loss of kidney function from renal cell damage. One very big thing with acute kidney injury is this can be reversed. It's just something that there's something going on with your body that causes your kidneys to go into stress, and so you just need to find out the cause so you can reverse it. So there are three categories that we group the causes of acute kidney injury into. So there's pre-renal, post-renal, and intrarenal. So pre-renal, think, is a volume problem. Highlight that. That is a volume problem. So you're going to have decreased blood flow to the kidneys. So that means you have a decreased circulating volume. And so this could be something like CHF, septic shock, really any kind of shock, because if you remember, shock is a volume problem. Hypotension, something like that. So pre-renal issues have a better outcome, more likely, because it's before the kidneys. So there's a better chance that you can detect what it is and that you can reverse the issue. So like I said, all types of shock because of the hypoperfusion, sepsis, hypotension, CHF, MI, those are the big ones that I would remember for pre-renal. So then signs and symptoms that I feel are more specific to acute kidney injury, that is a pre-renal cause. So you're gonna think of your signs, and this is why I think renal is kind of dense material, is because you really have to put everything together. So for signs and symptoms of pre-renal, you're thinking about signs and symptoms of losing volume or decreased volume, circulating volume. So that can be edema, diarrhea, vomiting, and just decreased cardiac output. So just think about it as the kidneys aren't getting enough blood. There's something wrong in the body that is causing that volume issue. Intrarenal, context clues, means there's a problem within the kidney that is causing the kidney to go into stress. Biggest one here, nephrotoxic drugs, infections of the kidney, so like glomerulonephritis, for instance, and also atubular necrosis, or ATN. That's like the number one that I have highlighted. But bottom line is it's like an issue within the injury. That could also be like artery stenosis of the kidneys, because that's like the actual kidney itself that's having the issue. So, yes. Okay, I have artery stenosis under prerenal and intrarenal. I don't remember that one being on the exam, but I'm pretty sure it's intrarenal. ATN is the biggest one. I remember that being on the exam, and you have to know that's intrarenal. So, and since it's intrarenal, that means that the kidneys are already damaged, so that's going to be a longer recovery time when compared to prerenal. Post-renal is an outflow issue. So remember, pre-renal is a volume issue, post-renal is an outflow issue. So basically, there's an issue after the kidneys that's causing you to have problems excreting. So like this could be BPH or neurogenic bladder, tumors, a UTI, kidney stones, something like that. Basically, just think there's an issue after the kidneys that's causing like to not be able to excrete. And so bottom line is, when you have all these issues, you get azotemia, which is a buildup of waste in the blood. So you're going to have azotemia either from this prerenal, intrarenal, or postrenal issue. Very, very important that you understand that. I know we had select all that applies about prerenal, intrarenal, postrenal. So definitely know that. I don't know if you guys went over AKI rifle classification staging. It just tells you where the patient is with their kidney disease. It stands for risk, injury, failure, loss, and end stage. I don't remember this being on the exam. I don't even know if you guys talked about it, but it's basically just like looking at the serum creatinine, your GFR, urine output, and there's just like different criteria for like different stages. So I'm not going to talk about that though. Okay, so AKI, there are different stages of AKI, and so it's very, very important that you guys are able to associate different symptoms with the different stages, because it depends on the stage for the symptoms. So like the biggest one that I can think of is how with like, so your first is like, okay, so for instance, potassium, with the oliguric stage, your potassium is going to increase, but with the diuretic, it's going to decrease. So like you need to understand like what symptoms are associated with what stage. I haven't mentioned this yet, but I would 100% recommend using registered nurse RN for kidneys for AKI CKD. She does an amazing job, and being honest, it made so much more sense after I like went to her website and just like recorded and just like figured out the stages a little bit better. So yeah, and if you see me looking down, I just like rewrite my notes and then I highlight things that I think are important. So that is why I have that. But it's literally just my notes copied because I have to write stuff out for me to learn. Okay, anyway, so AKI phases. So there's 3 phases. You have oliguric, diuretic, and recovery. So oliguric, the criteria is that you have less than 30 cc's per hour of urine, or you have less than 400 a day. And so usually this happens like within the first week of a kidney injury, but like some people might not even go to this stage. Some people might skip it because their injury might be so severe. So like, if you remember oliguria, that means you're not having urine output. So this is going to be a lot from like those conditions that we talked about with pre-renal that cause you to have a volume issue. But bottom line is oliguric, remember, is less than 30 cc's or 400 cc's per day. And it's usually within 1 to 7 days. It can last up to 3 weeks. So, yeah. Okay, so your signs and symptoms, these are important. So you're going to have an increased bun and increased creatinine, which if we remember, that means that there's something wrong with the kidney. So having an increased bun and an increased creatinine can cause LOC changes. It can cause itching. And so as a nurse, you want to make sure that you're like monitoring your patient's safety if they have this issue because of the LOC changes. You're also going to have increase in potassium, which this makes sense if you think about it because you're holding on to everything. So if you're holding on to everything, your potassium is going to increase because it can't be excreted. So your nursing interventions for this. Continuous tele, always. If you're worried about potassium, you put your patients on cardiac monitoring because if you remember, increased potassium can cause cardiac dysrhythmias, can be fatal. The way that you tell if someone has an increased potassium by a cardiac monitor, important, I remember we had a question on this, is a peaked T wave, a wide QRS complex, and a long PR segment. So that's important. So you're going to monitor their EKG, put them on tele, and then you're also going to restrict their potassium. So I think I talked about it in the first renal video I did, but that's where you're going to have to know like what foods contain potassium, that sort of thing. So that's another sign. Another one is increased body fluid. So you're going to look for, once again, those signs and symptoms that you're holding on to fluid. So edema, you're going to listen for crackles in the lungs. You want to monitor INO, daily weights. You're going to watch for hypertension, that sort of thing. So like I said, oliguric, it's because you're holding on to fluid. So just you're looking for signs and symptoms that you have fluid overload. Metabolic acidosis, we're going back to that. I'm really tired of all these spam callers calling me. Literally get like 5 a day. Sorry. Okay, so metabolic acidosis is, okay, so your hydrogen ions are excreted through the kidneys, through the blood. So if they can't be excreted, your blood is going to become more acidic. So you're going to have metabolic, because it involves the kidneys, acidosis, because it's acidic. So you are going to watch for that deep breathing, that Kussmaul breathing. Also look for change of consciousness and watch their oxygen. Another electrolyte imbalance, I have this one highlighted, is during this stage is hyponatremia, so decreased sodium, because you have so much fluid, you're holding on to fluid, so you're going to have decreased sodium because the fluid what am I trying to say? The fluid is like more predominant than the sodium, if that makes sense. So seizure precautions, they could go into a coma and confusion. Those are like the 3 biggest things you should remember with hyponatremia. And then also you're going to have increased phosphorus and decreased calcium, once again, because the nephron of the kidney can't regulate that if you're in the oliguric stage. So you're going to do a decreased phosphorus diet. You're going to watch for, I never say these right. You guys should remember this from patho. I literally can't say this. The sign where you tap the cheek, CHVOSTEKS, touch the cheek, and then Trousseau's sign is when you put the BP cuff on and they like put their arm like that. Those are signs of low calcium. So there's that. And then also, last thing for this is they're going to have concentrated urine. So their specific gravity is going to be out of range. It's going to be high because, once again, they're holding on to that fluid. So the little fluid that they put through is going to be very, very concentrated. Okay, so that is the oliguric stage. That is like, stop calling me. I literally don't know who these people are. But yeah, so that is the oliguric stage. So just think holding on to fluid. So think about your signs and symptoms. I would really recommend for like AKI and CKD, you guys do something similar to this where you just kind of like write it out, because it definitely makes more sense once you like put it on paper and whatnot. So metabolic acidosis, increased binding creatinine, increased potassium, increased body fluid, hyponatremia, increased phosphorus, decreased calcium, and increased concentrated urine. So for treatment with the oliguric stage is just dialysis, because we want to keep this stage as short as we can. So we want to get that fluid out. We want to get those electrolytes out. So we want to do dialysis, which is that filtering of the blood. So that is the oliguric. Like I said, not every patient is going to be in this stage, but you know, if they have that fatigue, that malaise, and all those symptoms, like, it means they're probably in this stage. Okay, so then the next stage is the diuretic stage, which is literally like the complete opposite. So this is when the nephrons can't concentrate urine, but they can remove waste. So you have osmotic diuresis. So basically, you're losing like a ton of fluid. I have this highlighted. You're losing 1 to 5 liters a day. Very important to understand. With diuretic, you're basically just peeing everything out, but it's like very dilute urine. So it's the opposite of with the oliguric stage. Your urine specific gravity is going to be low because it's going to be very dilute, not very concentrated. You're once again going to have increased BUN, increased creatinine, so know your normals for that. Your GFR is going to start out abnormal, but then it'll start to normalize in this stage. Azotemia is going to start to go away during this stage because you're like peeing everything out. So they're going to become more alert, become more oriented. They shouldn't be as fatigued. And then also they're going to lose potassium in this because, once again, potassium you excrete through the urine. So they're voiding all the time. So they're going to get rid of that potassium. So you might have to supplement them, and so you want to watch that. So your nursing interventions for this stage, once again, strict INOs, daily weights. You're going to monitor for dehydration, hypovolemia, and hypotension because you're getting rid of so much fluid that there's potential that you could go into either of those. And then you could also have tubular scarring and damage of the kidneys, so you want to make sure that you're watching labs. And that's all I have for the diuretic stage. So once again, I would know that you can lose like 1 to 3 liters, potentially even like 3 to 5 liters of fluid a day. You're going to have hypotension, dehydration, and hypovolemia are all potential risks. And then decreased potassium is also a thing. And once again, your renal labs are going to be increased, but they will start to normalize. Very important. Those renal labs, they will start to normalize. So then the last stage is your recovery stage. So this is when your renal function starts to improve. This usually takes anywhere from like 2 months to a year, but your tubular edema is going to start to decrease. Your GFR and your creatinine are going to plateau, and then they're going to start to get better. Your BUN will start to get better, and your urine output will go back to normal so that your body can maintain levels. If you skip the recovery phase of AKI, you go to CKD, which is chronic kidney disease. So, if you don't go through that stage, you're going to chronic kidney disease. Okay, so we talked about the different causes of AKI. We talked about all of these signs and symptoms and how they relate to the different stages. But like I said, I hope it makes sense what I was trying to say with how you have to be able to recognize that there's different stages of AKI, because as you can see, there's the oliguric stage where you have decreased urine output, but then you could also have increased urine output in the diuretic stage. So you just have to be able to recognize that those symptoms are very telltale of what stage you're in, if that makes sense. Sorry if you guys hear like noise in the background. They're working on my street. Okay. So now going to AKI treatment, treating the cause. That's the number one thing. So if it's a pre-renal issue, like I said, that means it's a volume issue. So fluids, you're going to give fluids, you're going to give them a bolus. If it's a post-renal issue, fluids aren't going to help because that's not the issue. The issue is you might have a kidney stone that you need to remove. You might have BPH, so maybe you need to get TURP. Sorry, I thought they were just... Cooper! So if it's a post-renal issue, you need to remove the obstruction. If it's internal, it's a little harder to treat, or like intrarenal issue, it's harder to treat because there's like damage to the kidney. And these are the patients that are probably going to go to CKD. Okay. So that is like treatment. But yeah, so both like pre and post renal, you got to treat the cause. Assessment findings, already talked about that. I think I mentioned this, but somebody that's in metabolic acidosis is going to be tachypnic. So they're going to be breathing very fast. As I mentioned in my first renal video, serum creatinine is the best indicator for kidney damage, but you are going to be looking at the BUN as well. Those electrolytes, like I said, you can either have hyperkalemia or hypokalemia depending on the stage. Hypocalcemia in that oliguric stage, hyperphosphatemia, that's probably not how you say that, in the first stage, along with hyponatremia in in the first stage. So then we talked about all the phases. I talked about you need to know the EKG changes for increased potassium that I mentioned. You should also know like signs and symptoms of increased potassium. So this is going to be stuff like muscle cramps because potassium plays a role in muscle contraction. So you might have like diarrhea, muscle cramps, weakness, even paralysis. And then treatment for AKI. So there's a couple different meds that we can use. So we have that acronym C-big-K-DIE that I had mentioned. I don't know. Just kidding. So this is how you would treat that increased potassium in the oliguric stage. So C-big-K-DIE. So hold on. Okay, so calcium gluconate, C. This is going to be given IV, and it protects the heart because it raises the threshold for excitation. So that's just like a protective agent that you would give to protect the heart. B is sodium bicarb. That helps to correct that acidosis, so it can move that potassium back into the cell. C, B, I is insulin. That is like your most rapid medication that you can give that's going to move potassium into the cell is regular IV insulin. G, glucose, is just because we don't want them to get hypoglycemic. K is K-oxalate. That moves potassium into the stool. So that's where you have to make sure they have bowel sounds. And then DIE is like diet and hemodialysis. Yeah. Okay. Other just like random nursing interventions for AKI, like I said, remove and treat the cause. If they have a positive reaction to fluids, that means it's a pre-renal cause. If they don't, then it's not pre-renal, it's probably post-renal. You are probably going to put them on a high carb and high fat diet. I don't remember the reason for that. You might have to restrict the electrolytes depending on where they're at, which I kind of already talked about that. And they also might need TPN to maintain their diet and prevent catabolism. I don't know why I feel like I didn't say that right. And then dialysis. Geriatric considerations for AKI. So the older population doesn't drink enough water, so they're more likely to get AKI. And they also tend to have a lower blood pressure, and your GFR can change due to medications. So if your GFR is below 60, you might need to alter those meds, and then you're at risk for building up drug metabolites. Okay, so that is what I have on AKI. Lots of content that literally took like 25 minutes, but I think it's really important to understand AKI and just like understand what's going on, because there are a lot of questions on the exam, I feel like, about AKI. Okay, so now we're gonna do CKD, which also is a little bit long. Originally, I was going to do AKI and CKD in their own videos, but then I slacked off, so now we're having to do it all in the same video. Okay, so CKD is progressive, irreversible loss of kidney function. That's a big difference between AKI, is this cannot be reversed. AKI can. The two most common causes are hypertension and diabetes. Very, very important. I know you'll have a question on that. And cardiac death is the most common complication. So people are going to probably die from CKD due to like a cardiac reason. Really quickly about GFR. So GFR is another it's like the best indicator of kidney function, along with like what stage of kidney disease you're in. So if you have a decreased GFR, it means your BUN and your CM creatinine are going to increase, because GFR tells you how well your kidneys are filtering. So the criteria for CKD, you guys need to know this. I know we had a question on this. A GFR for 60 for longer than 3 months is the diagnostic criteria for CKD. GFR of 60 for longer than 3 months is the diagnostic criteria for CKD. Sorry, I can't get comfortable. So the normal CKD should be around 100, or not, oh my gosh, the normal GFR should be around 125. Very important. So then there's a couple different stages of CKD. There's stage 1 through 5. I don't remember. I would definitely look over this and just kind of be able to differentiate a little bit between them. The only thing that I remember is if you are in stage 5, your GFR is less than 15 and you have to do dialysis. There's no ifs, ands, or buts. So that's the only thing I remember about the stages, but I would definitely look them over just in case. So, signs and symptoms of CKD. You don't have the different stages like AKI, so it's a little bit nicer. But you should be able to think about the symptoms of AKI and just kind of put them into perspective with CKD, because if you think about it, most of the symptoms that you see with AKI, you're going to see with CKD. So you're going to have increased body waste because your kidneys aren't functioning, so they're not getting rid of that waste, which means you're going to have that increased BUN and serum creatinine, which means that, like we talked about with AKI, you can have LOC changes, you can have itching, those sort of things. Metabolic acidosis as well. So just remember that tachypnic breathing for the metabolic acidosis, along with a pH less than 7.35 because it's acidic, and then that Kussmaul deep breathing, metabolic acidosis. I know we had a question on that. Hypovolemia is also much more likely in this stage because of edema, hypertension, and just that fluid. As far as your electrolytes go, you're going to have increased potassium, decreased calcium, increased phosphate, and increased magnesium. Very important that you know that. And so I remember this being a question too. So the reason that you have decreased calcium is because parathyroid hormone is going to be increased when you have kidney issues. So we're going to take calcium from the bones to compensate for this. And so basically that's why your calcium is going to be like low. And so then that also means that you can have bone issues. Very important to understand that is because you're going to have increased parathyroid hormone, which means that you're going to take calcium from the bone, if that makes sense. In this, with CKD, you're like hardly producing any urine. So remember, oliguria, less than 400 mils per day, and anuria, less than 100. Your glomerulus is probably going to be damaged, so you might have proteinuria and hematuria, which is blood in the urine. Erythropoietin is secreted in the kidneys, which is like erythropoietin is what stimulates the bone marrow to produce blood cells. So because that's not being produced, you're likely to have anemia in this stage. So make sure you know your normals for like hemoglobin and hematocrit. And then you're also going to have increased renin production since there's less fluid in the kidneys. And so that means you're going to have hypertension. Other things, decreased vitamin D, because once again, vitamin D is produced in the kidneys or secreted in the kidneys. So decreased vitamin D leads to decreased calcium. Can't concentrate that urine, so you're going to have that increased increased specific gravity. And then one thing I have written down that I remember I got from registered nurse RN is you'll have calciphylaxis, which is like yellow necrotic sores that you can get from like deposits in the skin. Okay, so that's what I had written down for signs and symptoms. Other things can be, once again, just like keep in mind your signs and symptoms of like fluid overload. So like headaches, edema, crackles in the lungs, hypertension. Yeah, pretty much said all this. Cramps from the increased potassium, along with dysrhythmias, decreased carb metabolism, that sort of thing. So that's what I have for signs and symptoms. And like I said, you're going to be looking a lot with labs with this. So creatinine clearance, which looks at your GFR, is the most reliable for this. And remember that criteria for your GFR of how to diagnose CKD. You're also going to have decreased sodium, decreased calcium, increased potassium, increased phosphorus, increased magnesium, increased creatinine, increased BUN, decreased GFR, decreased hemoglobin and hematocrit. I want to make sure that I told you guys all the same things. So I remember I just was like, I had so many issues like keeping all this straight. So let's talk through that. So decreased sodium is because, remember, we're holding on to fluid because our kidneys aren't working. So it's going to be very diluted, which means you have decreased sodium. Decreased calcium, remember, because we have decreased vitamin D production, and increased parathyroid hormone is going to take that calcium from the bones. Increased phosphorus, magnesium, and potassium, because you can't excrete those if your kidneys aren't working. Increased creatinine and BUN, because that shows kidney function, along with decreased GFR, because that measures how well our kidneys can filter. And then decreased hemoglobin and hematocrit, because the however you say that, isn't being produced in the kidneys. So yeah. And you also have decreased red blood cells because of that. I don't think I mentioned that. Okay, so the goal for care with CKD is to preserve kidney function as much as you can and reduce the risk of cardiovascular complications because, like I said, that's the most common cause of death with CKD patients. So you're going to use that drug therapy, that C big K dye. That's going to be used to treat that high potassium. Know what EKG changes. Once again, you're going to see with that. One thing I remember is so important with this is no NSAIDs because NSAIDs are nephrotoxic, so they're going to be harmful to the kidneys. So like ibuprofen, biggest example, I know we had a question on that. You can also use calcium and phosphate binders. You can give erythropoietin 2 to 3 times a week for the anemia, and you can also give vitamin D. As for nutrition, we're going to restrict those potassium foods again, encourage water intake, and we want to make sure that they're managing a good caloric intake and good fat intake. Once again, doing those daily weights, looking at their INO, doing labs, because that is how we are going to manage their treatment. Once again, I have highlighted because, like I said, I don't remember really anything on the stages of CKD except for a patient has to be on dialysis with a GFR less than 15 to be considered end stage, which is what I said. So that is AKI and CKD. I have a couple little things here just on the differences between them that I remember Schneider went over. So I'll do this just kind of as a review. So remember, AKI for onset is very abrupt, while CKD is more gradual, occurring over many years. Most common cause of AKI is acute tubular necrosis, that ATN, which is what I said. That's an intrarenal cause. And then hypertension and diabetes are the 2 most common causes of CKD. Diagnostic criteria for AKI is acute reduction in urine output and or elevation in serum creatinine, whereas CKD, it's that GFR less than 60 for more than 3 months and or kidney damage longer than 3 months. Reversibility, AKI you can potentially reverse, but CKD you can't. Mortality, AKI has a very high mortality, while CKD is not as common because CKD you can manage, whereas AKI, it's like very abrupt and sometimes you don't even notice that you have it until it's too late. Primary cause of death, infection kills with AKI, while cardiovascular disease kills with CKD. So, all right, so that is everything that I have on AKI and CKD. I'm going to come back to hemodialysis because if we're being quite honest, dialysis is not my favorite topic to talk about with this, and I honestly don't remember that much being on the exam about it. But we will still talk about it. Okay, so we are at 38 minutes. Nice. Okay, so now I'm just going to talk about some of your other renal issues. I would once again really recommend going to Registered Nurse RN and looking at her page. I think she does a great job of just like really condensing each disease process, and she also does quizzes that are like NCLEX style questions, and I'm not gonna lie, some of them are very similar to what Schneider's questions were. So that being said, like I did that. That's basically what I did. Like I said, I rewrite my notes in colors because I'm very extra, and the highlighted stuff is stuff that like she talked about, so that's why it's highlighted. Okay. Also, I could not find a PowerPoint on like any of these, so I really hope that you guys talked about these. I guess if you didn't, you can just skip this, but yeah. Okay, so first one I have is glomerulonephritis. So this is an immunologic process in which antibodies attack the glomerulus of the kidney. So the biggest cause of this is it's usually after an infection of the the throat, like strep. But it could also be due to like some other things. But I would remember that very, very common after strep throat. So if your patient comes in and they're having kidney issues and they said they just had a strep throat, that's going to be indication that they might have glomerulonephritis. So your signs and symptoms of this. So hematuria, which is blood in the urine. So they're going to have a rusty, smoky look to their urine. General edema and fluid overload. Very important because their glomerulus is damaged, so they can't filter things out. So they're going to hold on to that fluid. So they're going to have general edema. They might have crackles in the lungs, periorbital edema, very important. I remember that was like specific to this disease process. And they're also going to have hypertension and proteinuria. So the reason that they have that hematuria and the proteinuria is because basically their kidneys are so damaged, like their glomerulus is so damaged, and those antibodies are attacking it, that the protein and the blood cells can get like passed through. And so that's why it comes out in the urine, if that makes sense. Registered Nurse RN does a really good job of explaining that and just like the patho behind it. So for treatment of glomerulonephritis, you're going to treat the edema and the hypertension. So you're going to do hypertensive medication, antihypertensive medications, restrict their sodium. If they still have a strep infection and it's bacterial, then you're going to give antibiotics. You're going to decrease their protein intake because of the proteinuria. You're going to assess to see if they have nephrotoxic drugs. And if they have a strep like indication, then you want to do a rapid stress test. This usually happens in kids, and you guys will actually talk about this a lot more when you do like renal in peds. So this will come back around, but that is glomerulonephritis. Let me just make sure. Don't forget anything. Strep throat, blood in urine. Yeah. Rusty, smoky, whatever you want to call it. But yeah, so edema management and hypertension management are your two big things. I can't even tell what this says. Oh, okay. I literally cannot pronounce anything, if you guys have not figured out by now. Urethritis? Yeah, that sounds right. So that is a bacterial or viral inflammation of the urethra. It's usually in men because of an STD. This is just a really minor disease process. The only thing I have highlighted is that if you have purulent discharge, it's usually indicative of gonorrhea or chlamydia, whereas if you have clear discharge, it's usually like a viral infection or trick. So your education for somebody that has this would be to treat the partner. They need to have abstinence until the treatment, urine culture, and they can take a warm sitz bath. That is literally all I have. I don't even know if you guys talk about these, but better to be safe than sorry, I guess. Next thing I have is urethral diverticula. So if you guys remember, diverticula are those like little outpouchings. So you have you can have diverticula in your GI tract. And I've seen pictures of this from when I was at the GI clinic for Pop Health. And it's literally just like, it literally just looks like pouches in your GI tract. But you can have these in your urethra as well. And usually this is from some sort of obstruction. So it's more common in women, and it can usually result from like childbirth, but it can also be from infections like gonorrhea or just like frequent caths. Signs and symptoms, the biggest thing is suprapubic discomfort. But you can also have those just like general urinary symptoms like dribbling, frequency, dysuria, that sort of thing. So you just want to make sure that you get an MRI, ultrasound, and they might have to have surgery. Next thing I have is interstitial cystitis or painful, it's PBS. Is it painful bladder syndrome? I think that's what it stands for. But this is a chronic inflammatory disease of the bladder, and it's not infectious. Very important. I have that highlighted. Biggest thing with this is it's going to be super, 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 super painful. Very painful. And I remember we had a question on that. So it looks like a bladder infection, and that's what your patients are going to present to you with, but their cultures are going to come back clean. So it's not infectious. Like I said, diagnostically, we're going to do exclusion. So we're going to try to rule out, okay, is it an infection? So we're going to do those cultures. They might have lacerations on exam, and for treatment, we want to decrease their intake of irritants. So that would be like spicy, citrus, caffeine, alcohol, or hypotonic vitamins. You can use Elavil, E-L-A-V-I-L, to decrease pain, and you can also do fluids. So that is what I have for interstitial cystitis. Like I said, very painful. That's probably what you'll be tested on if you have a question on this. So next I have acute pyelonephritis. So I don't remember if I talked about pyelo in my first review video or not. I know I talked about UTI, but maybe I did, maybe I didn't, but I'll just talk about it again just in case. So pyelonephritis is from an unresolved lower UTI. So basically it's a urinary tract infection that ascends to the urethra. So this can cause sepsis, bacteremia, which is bacteria in the urine, and it can cause death. So you're going to have basically inflammation of the renal pelvis. Diagnostics are like the same as always. We're going to look at your cultures to see if there's an infection present, look at that white blood cell count, do a UA to see if there's bacteria. Signs and symptoms, two biggest ones I have highlighted: flank pain and CV angle pain on the affected side, which CV is that costovertebral angle. So it's like on the back where the ribs meet the spine. And you can assess for that with percussion. You're also going to have those signs and symptoms of a UTI, and this can be systemic. So you might have systemic symptoms like a fever. Treatment is going to be fluids, pain, and monitoring renal function. You would want to start them on broad antibiotics for like 24 hours while you're waiting for that urine culture. Make sure, though, I'm pretty sure this was a question on neuro maybe, that you get your urine culture and then you start the antibiotics, because you don't want to like alter how everything is before you get the culture. They should be drinking at least 8 cups of water a day. And if you have to hospitalize them with urosepsis, then that's what we're going to do. There's also such thing as chronic pyelonephritis, but that's more in like underserved areas that don't have access to medical care. Okay, so then the last thing that I have is nephrotic syndrome. So this is when the glomerulus is excessively permeable to proteins, but not red blood cells. So I used to get this one and pyelonephritis mixed up, because signs and symptoms are very similar. The way that I would say to remember it is glomerulonephritis is going to be that rusty, smoky, blood-colored urine, and then the edema and hypertension. You might have a little bit of proteinuria, but don't focus on that, because nephrotic syndrome, you're going to have massive proteinuria, like massive. You're going to have that anasarca and ascites, which is that generalized edema, hypertension. You're not going to have hematuria. No hematuria, no blood in the urine. So if you have that rusty colored urine, that is glomerulonephritis, proteinuria, nephrotic syndrome. Remember. You can also have hypoalbuminemia, which is albumin. So you want to make sure you're monitoring their albumin. because that is indicative of like how much protein they have. But like I said, proteinuria is like the biggest symptom to associate with nephrotic syndrome, along with hypertension, anasarca, ascites, that massive edema. So for your treatment, you're going to monitor their edema, so strict INO, daily weights, measure their girth, pitting edema, monitor for breakdown, and treat the hypertension with antihypertensive medications. All right, so that is everything I have on those like renal and renal and urologic problems. So I'm just going to go through my notes really quickly and make sure. So yeah, acute pyelo, remember flank pain, CV angle pain, and antibiotics. Urethritis, inflammation of the urethra. Remember, that's like the trick, or gonorrhea, chlamydia, so that's more like the education part. Urethral diverticula, usually in women from childbirth. Suprapubic discomfort is your number one sign. Interstitial cystitis and painful bladder syndrome, that's, remember, not infectious, very, very painful, and can be caused by irritants, so you want to make sure you teach them not to do that. I feel like we had 2 questions on painful bladder syndrome, and it was about like the symptom, which was like excruciating pain, and then also what you would teach your patients, which, like I said, that would be teaching them like smoking cessation, avoid caffeine, alcohol, hypotonic vitamins, aged cheeses, vinegars, spicy foods, citrus, that sort of thing. Glomerulonephritis, remember, can happen from strep, and that is going to be the rusty colored urine. So manage hypertension and edema. Nephrotic syndrome, remember, is going to cause that anasarca, which is the massive edema due to the hypoalbuminemia, and ascites and proteinuria. Okay, so that is that. And then there's a couple other little renal and urologic things here that I don't have written down, but I remember being tested on. So we already talked about that. Once again, I apologize if you guys did not do like what I'm talking about. You can just like, if Dr. Schneider didn't really talk about it, I would think you guys are okay, but I will make sure that I reach out to him and see if he can get me a list. So strictures of the, strictures are narrowing of the lumen anywhere in the ureter or the urethra. I really don't remember anything on that. Okay. Renal trauma, we did talk a little bit about this. So kidneys are extremely vascular. So, like a lot of, like kidney injuries can cause bleeding. So you're going to look for signs and symptoms of shock. So remember your shock symptoms: hypotension, tachycardia. You're going to look for gross hematuria, that sort of thing. So I just have highlighted renal trauma. Big concern is bleeding. There are renal vascular problems you can have. So, basically any problem that you can have elsewhere in the vascular system, you can have in your renal system as well. So nephrosclerosis, so that's buildup of plaque in the kidney arteries. So, same thing as if you have it in the heart. Renal artery stenosis, and then you can also have a renal vein thrombosis, which I thought was so interesting. Like, you can literally have a clot in your kidneys, which like makes sense, but you always think of like PE or like a DVT, not an RVT. And then polycystic kidney disease is a hereditary life-threatening condition characterized by large cysts of the kidney, and it is the most common life-threatening genetic disease in the world. So it is genetic, it usually presents itself 30 to 40 years. Signs and symptoms, I have 2 highlighted, and I know we had questions on these. Hypertension is usually the first symptom because the cysts are pressing on the kidneys so they can't perfuse. And so the nephrons, basically the nephrons think that they're not getting the blood that they need, and so they're going to release that renin. The other thing is that because of the cysts, these kidneys might be so large. And because they're so large, then it might be palpable. So palpable hypertension is usually the first symptom for polycystic kidney disease. There's usually no treatment, so you just kind of have to monitor. But we want to prevent infection with these patients, diet modification, and prepare them for kidney transplant. Ultimately, they have to get a transplant. Alrighty, so that is all I have for renal. The only other thing I'm going to talk about really quickly is dialysis, and then we will be good. Okay, let me get my notes for dialysis. Okay, so dialysis is the movement of fluid and molecules across a semi-permeable membrane to another into a solution known as a dialysate. So basically we use dialysis to correct electrolyte and fluid imbalances and to remove waste. So this is what we do when the kidneys are no longer doing their job and functioning, because, we talked about AKI and CKD, how you just have a buildup of electrolytes and how that can be really harmful. So we want to use this to treat those imbalances and cleanse the blood. So hemodialysis, so there's a lot of different types of dialysis. I have highlighted what I think you need to know because I feel like there's just a lot and it's really easy to get overwhelmed with dialysis. So hemodialysis is your most common dialysis treatment. It's about 3 to 4 hours, and we can do it inpatient, we can do it outpatient. The advantages is it's very, very rapid fluid removal. It removes a lot of potassium. It removes less protein. However, it is a disadvantage because you have to have a vascular access, so that can cause problems. There's more diet and fluid restrictions, and you can also have hypotension and anemia due to that blood loss and the fluid loss during the procedure. So that's very important to understand. You're going to have a fistula and or a graft. So remember, those are usually in the arms. So you're going to check fistulas to hear a bruit, which is that rumbling and swooshing noise caused by high pressure blood flow. Feel the thrill, which is that vibration. So those are good. We want to hear those and feel those. Usually we use the basilic vein and the radial artery. Like I said, complications, hypotension can result because of the rapid fluid removal, and they're at an increased risk for hypovolemia, along with muscle cramps. So another one I have is, I don't even know what these stand for. So I have SCUF/SLED. The only thing I have on here is it's a 10 to 12 hour treatment with fluid removal in the ICU. I don't remember anything on that. Next one is CCVH/CVVHD, which is also used in the ICU, and remove fluid. Once again, don't remember anything about that. The other one that you need to know is peritoneal dialysis. So you can do this at home. So advantages for this that you need to know is it's less cardiac stress, fewer diet restrictions, and you can do it at home. However, disadvantage is you are at a very high risk for infection with peritoneal dialysis. So that's the biggest thing that we're going to be monitoring for. So basically what happens is with this, you take that dialysate, you take that fluid, that dialysis solution, you put it through a catheter in your abdomen where the peritoneum, and that acts as that filter to remove waste products from your blood. And so then that fluid sits in your peritoneum for a little bit, and the fluid is then filtered out through your abdomen. So, like I said, infection is the number one risk at the catheter site in the peritoneum. So, you want to monitor for that. You can also have lower back problems, hernias, bleeding, and protein loss. It's usually done at night. Not always an option for everybody. They have to be very reliable on someone else or very independent to be able to do this. Pain in chest or shortness of breath is an issue because you might have weakness in the chest wall cavity from over time since we're putting so much fluid in. So if you have a patient that frequently has shortness of breath or chest pain with this treatment, it's probably not the best option. If they have pain, you want to slow the infusion and assess the pain and make sure it's not from peritonitis because peritonitis, like I said, is that biggest risk. So if you do have peritonitis and you have an infected bag, it would be cloudy, green, and purulent, which with potential fibrin. Do not empty if that is present. Do not empty. You also need a sterile field for this, so you're going to connect, drain, flush, fill, dwell, and then drain again. That's just the process. So connect, you drain, you flush, you dwell, have the fluid sit, and then you drain again. So, like I said, and with this, you don't have that central line or that access like other forms of dialysis, like a hemodialysis. You use that peritoneum. So, I would know the advantage and disadvantages and kind of complications from peritoneal and hemodialysis. So, remember hemodialysis, big complication is hypotension and hypovolemia, whereas peritoneal, it's peritonitis, which you would be able to see with severe pain that doesn't go away, and that altered bag appearance. Other last things that I have on renal, I have for kidney transplant. Remember that if kidney transplant patients, they're going to be on anti-rejection drugs like tacrolimus or Prograf. But if you have a patient on a drug for kidney transplant, they are at risk for infection and lymphomas. I'm pretty sure this was a question. If you have a patient on one of these anti-rejection drugs and you see a lump on their neck, that is very serious because that's probably cancer. Because with these kidney transplant drugs, your immune system is so suppressed that you're more likely to develop infection or cancer. Sorry. Medications, I know I shared this with you guys in the chat, so I would recommend looking at the reproductive and renal medication sheet. But like I said, remember IV contrast and NSAIDs are metabolized through the kidneys, so they're a lot more nephrotoxic. No, your calcium, your binders, no aminoglycosides are an antibiotic that can also be nephrotoxic, that sort of thing. Phosphate binders, know those, give them with a snack or a meal. And you guys should know your normal ranges. I think I've already said this, but know your normal ranges for your electrolytes along with your BUN and your serum creatinine and hemoglobin, hematocrit, all that fun stuff. So I feel I went kind of fast with this, but it's a lot of material and obviously you guys have some responsibility to be studying it and making sure that you're understanding it. I've said this before, but Dr. Schneider's PowerPoints that he's using are different than the ones he used with us. So I really don't know if you guys are even going over the same stuff. So if I talk about something that he told you guys not to worry about, then just skip it. But like I said, I will do one more review video on reproductive. I think there's maybe a couple urologic things that I might have skipped that I'll have to go back to, but overall, you guys should be good with renal. I would once again really recommend Registered Nurse RN, and you guys can reach out to me if you have any questions. So I hope you guys have a great weekend, and I will talk to you guys later.